Hello guys. The topic today we are going to discuss will be about dyspnea. The term dyspnea is a very pivotal sign that we see in both OP and NIP patients. So the dyspnea is actually a subjective experience. That means whatever the patient describes to you is what we know about that dyspnea or breathing discomfort. It could be physiological, psychological, social, or environmental. That means it's multifactorial. Anything could be its etiology. What could be the possible etiologies that we can look out for? See, dyspnea is divided into acute dyspnea and chronic dyspnea. Acute dyspnea means that it happens within few minutes to 24 to 48 hours. In those occasions, what we can think about is the patient is having an acute pulmonary edema, an acute exacerbation of asthma or COPD, a pneumothorax, pneumonia, ARDS, a pulmonary embolism, fallen body, laryngeal edema. It could be DKA, lactic acidosis, bulimia, or salicylate poisoning, or just it could be anxiety that we all see in very common. What happens if it's a chronic dyspnea? The patient already has a chronic condition, like it could be heart failure, he could be a COPD for a long term, chronic bronchial asthma, ILDs, interstitial lung diseases, severe anemia, obesity, or it could be carcinoma. So, with all these causes, how is dyspnea actually happening? For that, we need to see its mechanisms. Like the etiology, it has a wide variety of mechanisms, and the most common that we picked up here is first one, chemoreceptors. See, we have two kinds of chemoreceptors, that is the peripheral chemoreceptors and the central chemoreceptors that works in reaction to hypoxia. See, the peripheral chemoreceptors, what we have is the carotid and aortic bodies, which are very sensitive to PO2 and PCO2 and H plus in the blood. In case of a central chemoreceptor, it is very sensitive to PCO2 and H plus ions in the CSF fluid. Next would be increased work of breathing. That means we should give an increased effort for getting a little bit of air. It includes airflow obstruction in conditions like bronchial asthma, COPD, or a foreign body lodging in our airway. It could be pulmonary edema or fibrosis, or it could be ankylosing spondylitis, respiratory paralysis, or kyphoscoliosis. Any of these conditions could cause an increased work of breathing. Third would be an increased ventilatory drive. That means we are trying to get more air. In conditions like consolidation, collapse, pleural effusion, pulmonary edema, anxiety, pulmonary, uh, pulmonary embolism, etc. The fourth could be some structural deformity or muscle paralysis, which could be caused due to polio, Guillain-Barré syndrome, or myasthenia gravis. That you all know, it's very common. Next, what we're going to discuss is some terms related to dyspnea. See, the first term is orthopnea. What is orthopnea? Orthopnea is dyspnea that develops in recumbent position and is relieved by sitting up or by elevation. And it can be seen in conditions like COPD, bronchial asthma, congestive heart failure, or elevated diaphragm. The next term is about paroxysmal nocturnal dyspnea or PND, where attacks of dyspnea which occur during night, waking up the patient. Why this is happening? They have theorized this like it's caused due to decreased responsiveness of respiratory center and pulmonary congestion. And during these phenomenon, like when there's decreased response to respiratory center and pulmonary congestion, there could be increased sympathetic activity during the REM sleep. And this is this is a very classically seen in LV dysfunction, ischemic heart diseases, aortic valve diseases, or cardiomyopathy. How we can differentiate PND with orthopnea? See, the PND actually occurs around 2 to 2.5 hours after sleep. That means it occurs during the REM sleep. So when this episode occurs, the person who has a PND has to sit up or he has to stand up and try to get more air, and this is called air hunger. and he needs at least 30 minutes for his recovery. And during these episodes, he'll be having increased bronchial arterial pressure, airway compression, or pulmonary congestion. That's why he has to sit up or stand up and take in more air to get this relief. And it will be associated with angina, perspiration, or palpitation. And he'll be having a transient hypoxia also. That means that occasion his saturation will be slightly low. So how we can differentiate this from orthopnea? See, in orthopnea patients develop the breathlessness soon after they lie flat. So they have to get up or just make a head elevation, and by doing that, it subsides immediately. And it caused due to increased venous return to pulmonary circulation or compression of the diaphragm or postural episodes or due to postural. And it could be accompanied by if it is CHF, congestive heart failure, the patient could be having pedal edema, shortness of breath, fatigue or cough, then obesity, etc. And saturation will be normal at this point. The next term is trypopnea. What do you mean by trypopnea? That means the aggravation of dyspnea when lying on one side and relieved by lying on the opposite side. We can guess what the examples could be. It can be seen in CHF, where you get relief of the symptoms once you lie on the right side. Pleural effusion on the opposite side of the fusion, and in tumors. The next term is platypnea. What do you mean by platypnea? Platypnea is dyspnea that occurs when you sit or stand, and you will get relief once you lie down flat or in supine position. And this condition can only occur when there is shunting, that is veno-arterial shunting at the lung bases, and ASD, hepatopulmonary syndrome, pulmonary embolism or COPD, and in ARDS. The next term is bendopnea. What do you mean by bendopnea? That means dyspnea that occurs by bending forward. This is actually a very classical sign. It's seen in congestive heart failure. In this congestive heart failure, already we have an worsened ventricular filling defect. So once you bend down, that filling defect can be furthermore worsened, and that person will get being dyspneic. And when we ask the person to bend down, we have to at least hold it for 30 seconds to get this sign, and this is called bendopnea. The next will be how you grade the dyspnea. Actually, we have two kinds of classification grading systems. That is modified medical research council grading for dyspnea, where we using grade 0 for sternized exercises, grade 1 while hurling on level or uphill you will get dyspnea, grade 2 walking on own pace at level, grade 3 that means when you walk at least 100 yards or a few minutes you will get dyspnea, and grade 4 while we bath, while we rest, while we dress you will get breathlessness. That is MMRC grading of classification. Next will be a New York Heart Association classification, where class 1 you get dyspnea when you do ordinary physical activity, 2 on mild limitation, 3 on symptoms on exertion, and 4 at rest. This is all I am talking about dyspnea. It is a very important topic. Try to revise it as much as you can.